Radiation therapy or radiotherapy is based on using high energy X-rays, such as the same X-rays we use for, well, X-rays and CTs, but it's a lot higher intensity, so we use that in a targeted form to either treat tumours or to treat areas where tumours have been. Usually we use a number of beams coming from different directions and mould it around the area that we want to treat, and these days we're able to do that it's a lot more targeted than it used to be, and we're able to pull the dose off organs that we don't want to treat too much, like bowel or rectum, and actually focus the dose where we really want it. So the technology's just changed amazingly in the last since I started as a registrar in the late 80s. We were still drawing fields on X-rays with a Chinograph pencil. We didn't use CTs much. Now we integrate CT scans, MRIs and functional imaging such as PET CTs, and we fuse those all so that we can plan people's radiotherapy as effectively as possible. So the technology change has been massive in radiotherapy, and it's come a long way very fast. In fact, that's been one of the reasons TROG trials have been so helpful, because they've been able to utilise those changes of technology and evaluate them in terms of people's treatment. And some of the trials have actually been useful in actually rolling out new technology across Australia and New Zealand, and that's worked as a very good learning source for clinicians and radiation therapists, because a lot of these new trials involve dummy runs, and so that before you actually put patients on studies, you've already done the base work, and they know that the same thing can be treated in Townsville or Darwin as it can in Sydney or Melbourne or Wellington or Auckland. So that's how TROG has actually changed radiation therapy in this part of the world and kept it really up to date.